So hi, Stacey, how are you?
I'm doing well, thank you. Glad to be here.
Thank you so much for coming on. I just want to quickly just start off like from your journey of becoming a clinical psychologist and specializing in trauma treatment. Can you just like journey back and tell me a little bit about, what experiences kind of like led you to this field?
Yeah, absolutely. It's a very kind of dynamic journey for me. I started off in grad school with a very strong focus in child and adolescent psychology. And I did a number of practicum trainings working with kids and families, and it was wonderful, and I really valued those experiences. And one of the practicums that I got to do was a training experience working with kids in the foster system. And so, of course, with those kids, there's just an abundance of trauma, and really kind of fell in love with the work of treating trauma, and also recognizing that I was coming up against a lot of barriers in that space around getting families involved, especially if they're foster families, recognizing that foster families don't always have the same investment in therapeutic interventions as biological parents. Some foster parents are great, and they go above and beyond. But just kind of recognizing that these systems were creating a lot of barriers. And so I was curious about like what would this be like if I was treating trauma, but in the adult space, right? So I was trying to figure out a way to take down some of these barriers so I could feel like a more effective clinician, and hopefully the clients that I was working with would also feel like they were getting more out of treatment. And so my postdoctoral fellowship, I did a 2-year long PTSD trauma training where I was doing really most of our gold standard treatments, treating PTSD with adult populations. So this includes cognitive processing therapy, prolonged exposure. I was doing a fair amount of ACT in that space as well. And feeling like I was really making some improvements or some help, or I was really helping to change people's lives. So that was a really rewarding experience. And at the same time, again, recognizing like our tools are just lacking, right? Like our tools aren't doing what we need them to do because people are continuing to come in, continuing to struggle, and still have symptoms of PTSD despite our best efforts with the best tools that we have. So that kind of led me on a little bit of a journey into academia, and I took a tenure track position for a period of time. And then I had an opportunity to join the Center for Psychedelic Drug Research and Education at Ohio State University, and really help launch a PTSD trial for veterans, treating them with psilocybin specifically, a psychedelic that has been investigated more recently in terms of the treatment of treatment-resistant major depressive disorder, but certainly we were curious about what potential opportunities we had looking at this substance in the world of PTSD. So because of my trauma expertise as a clinician, I was brought on board to help kind of launch this treatment, and we're kind of well into it at this point and enjoying it.
And so like, your past experience, like working on that and then like kind of that transition into what you're doing right now, what did you like, take from that and have like kind of used it in your current field of work? Like how's
So
that kind
there,
of like influenced what you're doing and on what and educated you, which is different from what anyone is just like coming in day one with like a completely fresh plate.
yeah, so there are a lot of skills that I learned as a trauma clinician that are very helpful in the space of psychedelics. Not just psychedelics and PTSD, but just psychedelics in general. And a lot of that comes with really learning how to sit with people who are telling you about the worst thing that's ever happened to them, and holding a space, a supportive space for them to share those details and to not feel re-traumatized or embarrassed or ashamed of what has happened to them, and also to provide them with a safe space where they know that they can endure in telling this story and not feel that they're going to lose control, or if something happened, there wouldn't be any way to take care of it, right? Because they have a team, or I'm on their team to make sure that they can get through this. And so, with psychedelics, there are challenging experiences that people can have when they're using psychedelics, even in a medical setting. And so one of the things that I learned how to do of sitting with people while they're doing these really challenging things has come in very handy in the psychedelic space, where someone takes a psychedelic and they have a very challenging experience and they're feeling a lot of anxiety. Maybe they're feeling confused or disoriented. And I'm there to help create that safe space in the way that I was before. It's a very different kind of therapy or therapeutic experience as a guide or a therapist than in the traditional sense of PTSD treatment. Because I'm not walking them specifically through an intervention while they're taking the medicine, but I am there in that important way to make sure that they're safe, they're comfortable, and they trust me.
So how is it different from like talk therapy or traditional forms of therapy? I understand like you're not going to be talking through or walking them through the experience and like kind of guiding them, but you're there almost like a support, and they're aware that like you're there for them. But isn't that what a therapist would do? I know like I do get it, I understand it, but I want you to like almost like expand on it and break it down for someone who has never experienced talk therapy or psychedelics in the therapeutic form.
Absolutely. So, clearly the biggest difference really is just being in a state of conscious awareness. And so we can really take advantage of that in traditional talk therapy of, asking somebody about what has happened to them in their past, having them go through specific activities to figure out where their stuck points are, right? What has this trauma taught you about who you are? What the world is about? Are you safe? Are you not safe? What you can expect from other people. And trauma has a really powerful way of teaching us lessons, which of course we want to learn because it's helpful for our survival as a species. And at the same time, in our modern world, it can create a lot of problems for us. So we end up kind of narrowing our life and living in this space where we feel safe, but we're not doing the things that give our life meaning. And so what we're trying to do through these talk therapy interventions over a period of time, typically protocols are about 3 months, is we're really trying to either challenge somebody's thoughts that they have come to automatically have after their experience. I can't trust anybody. And start to challenge those in somewhat of an experimental kind of way, right? Like I encourage my clients to go out there in the world and test these theories that they have, that their mind is telling them about who they can trust and who they can't, right? That doesn't mean go out into the world and trust everyone, because that's not a safe way to engage with the world. But how do we create balance in people's thoughts? So that's kind of one way to do it. And through evidence and getting more data, the hope is that these thoughts start to become more balanced over time. Another way to do it is just through kind of a more behavioral model of prolonged exposure. So a lot of times people just get very distraught by their own thoughts or about things in the environment that can trigger reminders of their trauma. And so part of it is through this process of habituation, right? How do we just kind of get somebody to get used to having memories of their trauma, to know that they can have a memory and they can still be okay? We know we'll never get rid of the memory, but can we get someone to a place where they're not feeling so reactive when they have the memory? That's the same for anything in the environment. How do we expose somebody in a way that that allows them to just kind of get used to that and know they're going to be okay, so they're not as physiologically reactive? And that's what we do in prolonged exposure. Both of those are talk therapy treatments. They are effective. They do work well for a lot of people. They don't work well for everybody, and a lot of people feel very stuck. And so this new treatment psychedelic-assisted therapy is a mix of a medication treatment with talk therapy. The way we've structured it for our protocol at Ohio State with veterans is 4 weeks of 2-hour sessions of prep. Prep is really about building some sort of rapport between two therapists and the participant, right? We want them to go into their dosing session feeling like they can trust us, that they know what to expect of us, that if they need help, they know how to ask for that in safe ways, and they know what we will be doing to help them and support them. They also know that we're going to be monitoring their safety physiologically. So if their heart rate gets too high, their blood pressure gets too high, we're there to intervene. So we're kind of like working this out for the first 4 sessions. And then come dosing day, we're really hands off. So they take the medicine, and we do really believe that the person comes in with their own wisdom about their trauma, their experience, and how to heal. And the medicine is just a catalyst to help them get there. And so we want them to have an inward experience that's not disrupted by the therapists, by distractions or question asking or trying to guide this in some way that we think it needs to go, when really we think that they hold the answers. So we're really hands off. We're there to support them, let them know if they have a challenging experience. We can walk them through relaxation exercises, deep breathing. We can help down regulate. And we're also going to be there to monitor their safety physiologically.
So going back a little bit, you kind of mentioned that, people who have trauma have trouble trusting people. So how would that kind of change, especially when you're like there to guide them and they're not used to this? And like, I'll give you this, like something that is the personal thing for me as well. Like talk therapy doesn't work for me. I'm not comfortable with opening up with people, and then having that in a setting where I'm on psychedelics, or like I would be prepared to be like completely trusting someone else to be there for me, would not be easy. And I would like assume that would be the case for someone who has got severe PTSD, especially someone like who's a veteran, who's not used to having that safe space to be able to just like process things.
Absolutely. Trust and control really are the two biggest things. They kind of go hand in hand a lot, which is, like, understandably, they're going to have a hard time coming in and trusting us, or they want to be able to have control. And if you're thinking about a psychedelic, right, you're completely giving up control and you're putting a lot of trust into other people. So we are asking people to be vulnerable in really powerful ways that can be helpful therapeutically as well. And so a lot of this is just kind of naming it and putting it on the table. When we do our really thorough screenings to determine whether or not somebody should be enrolled in treatment, this is also something we're kind of assessing along the way is this somebody that we think we can develop rapport with in a fairly short amount of time? That's, I think, one of the good things about a phase 3 clinical trial, is we're doing everything to reduce risk. So we don't want people to have adverse events that we aren't anticipating. But it also doesn't necessarily capture the population of people who have PTSD and who are struggling with symptoms. In our experience with veterans, what I can say is that all of the veterans that we have enrolled and that we've screened are veterans who have been dealing with PTSD symptoms for 10 or more years. And they've tried everything, right? They've tried all of the medications. They've tried all of the therapeutic treatments. And some of them are just at a point where they're like, I will do whatever I need to do to get some relief here. And so I think part of that is also playing a role in why some people are willing to go into this very vulnerable experience with 2 brand new people and see if it'll work.
So now that people have a lot more access to psychedelics, so there's a lot of changes in the law where people can actually get this on their own, or again, there's just straight up access, like sometimes legally, not legally. Then they go and there's a lot of literature out there where it says psychedelics do help with severe PTSD, be it veterans or someone else, someone's dealing with depression, there's a solution for that. Do you think that doing something like this on your own without like someone who's there to guide you, who's there to support you, just like someone who's a strip sitter, or like even helping you work with the, like, you, like you said, there are like weeks of you just having like conversations, getting them comfortable, guiding them through the process is not there. They just go straight up, get psychedelics and like try to like work on their trauma, so to speak. What would be the difference? What could be the pitfalls, and what should they, like, how would you recommend it? And if they do, what are, like, what should they prepare themselves with?
Yeah, those are really great questions. You're absolutely right. I mean, it is becoming, well, it's just becoming more public, right? That psychedelics could be helpful for these things. And also there are places in which people can access these substances. And so, we're hesitant about encouraging people to just go out there and see what happens on their own without any support. We've done naturalistic studies in our center looking at people who have done things like that, and there are some cases of people just kind of having spontaneous recovery. But what we don't know is what it is about those people that leads to that. There are some hypotheses or some suspicions, right, that maybe these people just are a little bit more psychologically minded or insightful, or they've gone through therapy before, and so they have a skill set that they can utilize. But we also know that there are more adverse outcomes as well when people do this in an unstructured kind of way. If we look at our clinical trial data, where everyone is getting a psychedelic in a very controlled environment, where they have two supportive individuals to help them, there's been a period of time where there has been trust gained. Adverse events are very rare. They don't happen very often. And so while we can't know for sure that it's because of the environment and because we're creating the right set and setting, we're getting people oriented psychologically to what it is that they're going to experience. So we're asking them, like, what are your intentions? What do you want to get out of this experience? And helping them identify what's a reasonable intention versus something that is not necessarily attainable. And so we're really trying to create that space. And we know when we're doing that, we're also seeing fewer adverse events. And so there is risk involved with doing this independently and not having support or structure, but there also are harm reduction strategies that people can use by finding a therapist who has some training in psychedelic therapy, specifically in terms of helping people identify where to get the substance from, what's a safe place to obtain it, what are the things that they can do to prepare for their session, what resources do they have to know that there's somebody with them while they take the substance, or that there's numbers that they can call if they're having a challenging experience and somebody can be on the other end of that line to help walk them through that. But then on the other side of it, which we also think is an important variable, which is integration, right? So there's something about just having a psychedelic experience, but then there's something different about, let's figure out what that meant. And people might not be doing that on their own, or might not be connected with people who can help them do that. And so in terms of harm reduction, how do people get connected with the right trained guides or therapists to be able to help them make meaning of that, so that they can integrate that into their life in a meaningful way, to kind of expand, right? We were talking about living in that narrow sliver, like how do we help people expand into a more fulfilling life that they're seeking, rather than just hoping that will happen.
So there are loads of groups and communities that have been built around psychedelic therapy. They're like psychedelic ayahuasca churches, you name it, especially in the US, not from here, like in the Middle East, there's none of that. What I've noticed as a community, they almost like on a monthly basis or every 2-3 weeks, they go in and have like, ayahuasca or DMT, and they're tripping so frequently. And like, again, this is my opinion, and I would like to like see what your insights are. I feel like there's no integration, like you did mention, and that's the reason why I bring this up. There's no integration, and they don't seem to be healing. It's almost like, yeah, I'm looking for the answers, but then I get like, an insight or like something, and then nothing happens after that. And there are so many communities where just like, okay, now this is allowed, this is legalized, I'm doing this, but there's not enough structure set in place for integration or like learning from that experience or like building upon it. How would you mitigate that, one? And second, is there a board or like something that's building up? Because this is fairly new. And there's nothing that is like, okay, legal body that's kind of like putting the checks and balances in place.
Right. So in terms of the first part of that question, I think that's also another place where somebody who has training in harm reduction methods can be helpful. Helping people navigate the space. Sometimes it's an underground space. Oftentimes it's an underground space of places or organizations that are providing these treatments, and helping people to know what they're even looking for, right? Because when you watch or read something in media, typically it's just about the dosing session. It's not about the other stuff that's not as exciting, right? The 8 hours of preparation that we put into this to make sure people are safe, or the really difficult and challenging complexities of what integration even is. And so we mention it, but we focus less on it, even though the focus really should be more on those aspects, because I do think they're more important. And so getting connected with a clinician or a knowledgeable person who can help people know where to look and what to look for, I think is really critical. Because there are places that are just offering these dosing sessions and then kind of send people on their way. And while that can be helpful for some people, we're definitely not seeing the success rates that we're seeing in clinical trials and that kind of structure. And a lot of that has to do with the fact that these substances are Schedule 1. These are the most rigorously controlled substances in the United States. And so that limits our ability to even do things like regulate and help people, guide people to the right places, and have some sort of credentialing system that allows people to have a mechanism or a tool to know what's a safe place to go versus a not safe place. And so that's a big issue that we're combating. It also prevents us from being able to effectively and quickly do research with these substances as well, because there's so much red tape.
Speaking of red tape, what recommendations would you like if you were like someone who's like speaking to government and like influencing policy, what guardrails would you recommend there be so that like things a little bit more streamlined, a little bit more like structured, so things make sense from like your expert point of view?
That's a really good question. And I would not say that I'm an expert in that aspect of this. I do really think where we need to start is with assessing and figuring out the scheduling mechanism for these substances. Because I think with kind of opening that door, it's going to allow us to know who's providing these treatments in our nation, what treatments they're providing, how it's done, what checks and balances that they have, and some sort of centralized system for this. And that doesn't exist, which puts people at risk. Especially if we're looking at the fact that there might be some sort of medical value to these substances, because it's hard to then justify keeping this scheduling system, or at least keeping them in that scheduling system in Schedule 1 when it doesn't really meet the definition. In addition, I think we also need to be really thinking about, particularly as we're approaching the likely FDA approval of MDMA-assisted therapy for PTSD, is how are we training our workforce, right? Like, how are we getting our workforce ready? and what systems are in place to ensure that our workforce knows what they're doing, that they're doing it safely, they have the required training that they need, and also they're doing it in a facility that has everything that it needs to be able to support somebody in a dosing session. So this is a very interdisciplinary treatment, unlike anything that I've seen in the psychology space. So at this point, we're bringing in psychologists, we're bringing in social workers, we have nursing staff, we have medical staff, MDs. There are just a whole host of people involved in this process. And right now, we're just kind of piecemealing what people we can find in our organizations to do this. But we'll need systems to be able to roll that out, and that needs to have oversight. And there need to be ethics around it. We're asking people to take a substance that's completely shifting their conscious awareness. And so what are the ethics that we have around this? And how are we doing this in a way that's also honoring sometimes the indigenous groups that have been using these treatments for thousands of years?
Speaking of medical stuff, you recently had one second, just hold it, a medical paper talking about the attitude towards assisted therapies and what their belief systems and attitude towards them are. So like psychologists, social workers, and psychiatrists. First of all, why did you delve into this? And then what are your insights?
Well, I feel really lucky to work in a center that's housed in a college of social work. And so there's a lot of social work influence in what we do. And so a lot of the values of social work really just kind of flow through our center. So social work was a clear interest to us just because of where we're housed and our own personal interests. There are a number of psychologists on the team, including myself. And so psychologists were also another interesting group of people we wanted to assess. And we also have medical doctors on our team as well. And so this kind of makes up a good portion of the individuals who you see on protocols for psychedelic-assisted therapy. And because we have such an interdisciplinary team made up of the people who we wanted to assess, that's how we got to these three groups. Of course, there are more credentials that we didn't assess that are important to assess, but that's how we landed on these three. I think there was a second question and it escaped me.
No, what I'm asking is how is the attitude over the years? How's it changed? And what would you do to again, you're opening up to a bigger, wider population, people working in this industry or this field, but not specifically to psychedelic treatment. How has the attitude changed and how would it change in the future? Like, how do you foresee this?
So we haven't done any longitudinal studies at this point to see how attitudes have changed. I think we can make assumptions about that, but they wouldn't necessarily be rooted in the science or the research that we've done. What we can say is at the time that we did these surveys, there's still a fair amount of kind of misunderstanding about what this treatment even is. And I think that has a large part to do with how is the treatment being portrayed publicly. And so I think a lot of professionals do still think that it's, oh, someone shows up to a clinic, they get some psychedelics, and then they go home and that's it. And that's really not what this is. And so, clinicians are not buffered from cultural stigmas. These substances have been taught for many years to be of the most dangerous substances that we can put into our bodies. They will scramble your brain. You'll have all of these unintended. You'll become psychotic, and so. We've all learned those lessons, and here we are now as professionals, and we're trying to combat that stigma, and that stigma still is very present and very much impacts the way people perceive the acceptability of these treatments. I do think it's changing, though. as much as there are issues around kind of the public display of this treatment, I do think it's helpful too, right? Because it's bringing more awareness to this, and then it breeds curiosity, and then clinicians are like, what is this really? And they go do their own research, and then they start to really fully understand exactly what this is. So I do think that this is changing. We're making headway, and I'm feeling optimistic that in the not too distant future, particularly as this rolls out on a broader level, that there'll be even more acceptance of it.
And what are the results like? Like, I'm not a numbers person, but someone who's looking at it, like, okay, yeah, there's a lot of talk, but then I don't see any result, like, unless I experience it myself. And as much as there's literature out there talking about the benefits of it, people want case examples. Have you seen, like, massive improvements in people's life? Have you seen a massive shift in people who've got like severe PTSD, and then they come into your clinic or your center, and then they leave 1,000 times better in a shorter period of time because you've given them the tools, you're there supporting them, showing them, like, the path to recovery in a way?
We have a glimpse into that. How is this changing people's lives? And in the very preliminary data that we have with the 3 people who've gone through our treatment in our PTSD trial, we assess their PTSD using an independent rater. And the score on their assessment on average for all 3 of them was a 40, which is, pretty severe PTSD symptoms. And then at 1 month follow-up, after they'd done both of their dosing treatments, their average was a score of a 3, which is subclinical PTSD symptoms. So of course, this is just an N of 3, but it does mirror what we're seeing with psychedelics and other clinical trials for other types of mental health concerns, including major depressive disorder, including different substances like MDMA. So, we're tracking some similar outcomes. What we don't know is what happens when these screening processes aren't as rigid. We talked about that a little bit already. That came up earlier, which is when more people are involved, when the protocols change. So maybe there's not as much prep involved. When dosings change in terms of, milligrams, 1 dosing, 2 dosing, 3 dosing. When those things start to change and we're in the real world and we're collecting real world evidence about how this is actually working, I think that will be really telling. I don't think we're going to see the types of outcomes that we're seeing now. I think they will be less effective. And so just kind of keeping that in mind, there are issues with clinical trials. They are gold standard research, but they don't answer all of our questions. Another question that they don't ask are what happens long term. We're following our participants 6 months out after their dosing session. So what happens beyond 6 months? I think some of our longest term clinical trials are around 12 months. We're getting ready to launch a clinical trial or a follow-up, long-term follow-up in collaboration with Johns Hopkins to look at what's happening even beyond the 12 months that they captured. And for some of these people, it might be 5 years later. So we'll start to get some of those answers in terms of people who were treated in a clinical trial setting with very rigid structures and criteria and screening processes. But the FDA approval, potentially with MDMA assisted therapy for PTSD, will likely answer more questions for us too.
So what's the difference between, let's say, MDMA? Like, I think your field of work is in MDMA, but what about like DMT or like psilocybin there, and then ketamine? Ketamine's being used by a lot of people for like working, especially with depression. So does one substance differentiate from the other? Does the dosage change? How do these like key things, fine tuning, affect, like, again, therapy itself or like working on a patient?
Yeah, so a lot of those questions we don't have answers to yet. The most rigorously studied substances in clinical trials have been MDMA for PTSD, psilocybin for major depressive disorder. Psilocybin, I believe, also for substance use disorders. DMT really hasn't taken off in the clinical trial space quite yet. And so in the clinical trial space, in terms of research, we don't have a lot of answers to that at the moment. Our hope in the CPDRE at Ohio State is to launch a clinical trial with DMT in the next 6 months.
I
And
think
this
I think there was a study done on like long dosage of DMT, like it was I think intravenous, where it was, because I know like a session with DMT is like last 15 minutes. Then there was someone who's like doing, I can't remember the name, but basically long term, where it's like it's the dosage keeps being injected, and then there's a study on the effects of that. Like how would that differ versus MDMA? Because like I think the key factor is like the duration of your trip.
Yes, and that's primarily why we're interested in studying it at Ohio State, which is in terms of a clinical tool, in the system that we have in the United States for healthcare, DMT could be really advantageous because the effects are just much shorter acting, as opposed to psilocybin, which is an entire day endeavor. So that is why we're curious about it. It is very potent, very strong substance, and so there are questions around what exactly is the clinical utility of this. We've collaborated with different organizations to collect data from people who have gone outside the United States to places where psychedelic treatments are illegal, and just do some naturalistic or cross-sectional research on their experiences. And some of the data that has come through has been with DMT. A lot of the data I've looked at personally has been a combined intervention of ibogaine and DMT. So one day they get ibogaine, the next day they get DMT. There is integration. There's also some prep. And in terms of PTSD symptoms with that type of treatment, combined treatment, we see a pretty substantial reduction in their PTSD symptoms. Also a very substantial reduction in alcohol use, cognitive flexibility, different factors of cognition in terms of, feeling less foggy or clear-headed, and a range of other mental health factors as well. So the jury's still out on, and this is a big question I have, which is, okay, what substances here are at play? And how do we tailor these substances to specific mental health concerns, if we even need to? So I don't even know we've answered that question. And maybe it's more about the person. Maybe we need to tailor the substance to the person and what their preferences are, what they want their experience to be like. So yeah, I mean, I think we're still really trying to put the pieces together here, and there's so much for us to learn because there's just such a vast space of what we don't know. And it's like we have a light, right? And we're just kind of shining it around, and we get like little pieces, but it's still an entire dark room that needs to be illuminated, and hopefully through our incremental processes, as a space and as a space of research, we'll start to illuminate more of this space together.
So you've kind of mentioned like, the benefits or like the uses of psychedelics, like you're talking about PTSD, talking about depression, substance abuse, trauma. It almost sounds like a panacea of like everything. Like that's how it's kind of also like spoken about in public spaces. I know that it's not the case. First I want you to like kind of untangle the mechanism of action. I know we don't completely understand how they work, like we're still like exploring that, but for someone who has no idea of it, what would you kind of like lead them in, like this is how they work, this is what like they are going towards which part of your brain or body or whatever, and then that's how they are like kind of working towards like dealing with your issues of PTSD, be it depression, like what is the mechanism?
Yes, still lots of questions about mechanisms too, and not having expertise in neuroscience, probably my explanation would be fairly limited. But in terms of kind of like a rudimentary explanation, these substances are really acting on these 5-HT2A receptors in our brains. And there seems to be some correlation between taking these substances and then it kind of takes some networks offline that are typically online for us because they're adaptive, right? Like they help us just kind of like get through the day, sometimes in a very automatic way. And this is called the default mode network. And while it's helpful, it can be really unhelpful because when you get stuck in automatic ways of doing and thinking and feeling, then that just takes over. And so if we can take that system offline and we can eliminate some of the barriers that prevent us from being able to think about ourselves and our perspectives and our emotions in new and novel ways, it seems to also like allow the brain to communicate with itself more fully, at least for a period of time. So it seems like there's this critical window that we have, which is why we think integration is so helpful, right? So an analogy we often use is it's almost like you get if you're skiing down a mountain and you're stuck in the same grooves over and over and over again, if you get a fresh coat of snow, you now have the ability to find new paths and figure out different ways to go down the side of this mountain that aren't going to keep you stuck, right? You might find more effective, efficient, or enjoyable ways to ski if you have this new fresh coat of snow. So in some ways, a little bit like a reset button or a fresh coat of snow, where people then have the flexibility in their thinking to consider different reasons for why things happen, or to slow down enough to consider what are my options for responding and which one aligns with who I want to be. So that's what we think is happening. Of course, over time, it seems like the interconnections between the brain kind of go back to something that was more similar to before. So there's this window, and that's where we feel like the integration is really playing an important role, is when the brain's kind of functioning a little bit differently, how do you take advantage of that to help somebody establish new pathways?
I mean, especially in the psychedelic space, in the space that's promoting it, there's always a lot of talk about the benefits of it. There's not much talk about like, the responsibility of like what could happen. Like you did mention like having someone who's guiding you, but there have been cases where people have had psychotic breaks
Mhm.
and then they don't recover from it. That's becomes a lifelong issue. Because there's not enough like promotion of the, like the pitfalls of it. There have been cases people having psychedelics at home or like in a space without a professional, and then their lives are not the same. Like even I think I don't remember the book, but there was Tell Your Children, I think, in that the author mentions where like consistent use of marijuana at an early age when your brain is not completely developed can lead to like long-term issues where you cannot recover, and it takes years and years off people's lives. Can you talk a little bit about that and like from your like expertise?
Absolutely. Just like any substance, there are risks to taking them, and there are people who have taken psychedelics, and we've studied them kind of more of a naturalistic setting and asked them historically if someone had a psychotic break and they just taken a psychedelic, right? We're kind of putting the pieces together. And so yeah, this is absolutely something that we're thinking of. The FDA is definitely thinking about it. We are excluding anybody from a clinical trial who has any history themselves or close family history of any kind of psychotic symptoms. And so we don't want to minimize that, right? Like that's a very severe mental health outcome that could result from from taking this substance. And so we want people to be educated about that, especially in a setting where, because we don't have regulation around this and people are doing this on their own, this is another harm reduction strategy of how do we inform people or get people to a place or connected to other people, professionals who can help them explore what their personal risk is for a journey that they might be curious about taking. And so I think it is important. It's very important that we not only talk about how is this potentially helpful, or what's coming, or I don't want anyone to walk away from this thinking, oh my gosh, we have this new wonderful magic bullet that's going to solve all of our mental health problems, because that's absolutely not the case. There are plenty of people who aren't seeing relief in their mental health symptoms in the way that they want to, or their symptoms come back after a period of time. And there are so many unanswered questions. So it's not a magic bullet. This isn't the thing that's going to save us in humanity. It does, I think, have potential to do so, but we also must be clear about what the risks are when taking these substances, and the importance of exploring the idea of taking these substances in safe ways that are going to do the most to reduce somebody's harm or reduce their risk for an adverse event.
Switching gears slightly, your research program includes studying impacts of stresses like cyber victimization and problematic media use among adolescents. How do these stresses affect the psychological well-being of like adolescents, and what interventions do you find that are promising?
Well, lately there's just been a lot uncovered about the impacts that media use does have on youth, and particularly the intersection of problematic media use with the pandemic, where media use went way up. There was more opportunity for problematic media use, and now we're just in the repercussion of that, which is a public health issue of young people who are struggling with mental health concerns, including suicidal ideation. And right now, my focus with research in that space is similar to some of my focus in the psychedelic space, which is how do we help clinicians understand this space and give them the tools they need to be able to screen adolescents while they come in for therapy, or while they're in their pediatrician's office, or when they're with any provider for that matter. Because we need to have better tools to be able to identify adolescents who might be at risk for problematic media use, and then of course adverse outcomes because of that. So a lot of what I'm doing now and focusing on with my research team is how do we create something that's going to be helpful, and how do we roll that out? How do we educate our workforce so that they feel like they have what they need? Because when we ask them, like, how do you handle these situations? They kind of all have their own kind of way of doing it, which is helpful, but there's no standard practice for it. And a lot of them are feeling like they just don't have resources to be able to help their youth that they're working with navigate this space that's changing all the time. And that's very stressful for them.
I don't think psychedelic use historically has just been a Western idea, but I feel like it's against substance. Like ibogaine is been used in Africa for ages. Ayahuasca has been used in different parts of like the other countries. Like, you could go into tropical countries where there are in the Amazon jungle, people are using psychedelics. There are different forms, different approaches, but as across the board, it's like there has been a way of going like, okay, psychedelics are bad for you, but then there are substances historically culturally ingrained which people are using, like, okay, there is holotropic breathwork to reach that same state. And there are, again, each culture has a history of using psychedelics in such a way or reaching that psychedelic state. Like you're working with MDMA, but someone else is using ibogaine. It's almost like we as a civilization across different countries are seeking that. There is something within us that is seeking it because we want to heal. Like there's an ingrained need to like heal our traumas. But what do you feel is the disconnect?
The disconnect between what specifically?
Like again, culturally, we feel like okay, there has been like okay, there's war on drugs where people are like okay, psychedelics kind of fall under the same category as like something like cocaine. And now it's changing, the conversation is changing, but then this happened as a civilization across for everyone. It's not just the West. It's not just like, let's say, I'm originally Indian, in India as well. So like this, and psychedelic use was there across everywhere, like be it the West, be it the East, everywhere, different forms of it, but it was used. And it was used for its medical purposes to heal trauma. It was not just used as, I know it was used also like almost like a recreational drug, but it was used also across the board to heal from trauma. And this is
Yeah.
not a brand new idea, but then there's been a disconnect. So why
Yeah.
was that like from your opinion, what do you feel is the reason for that disconnect? And how are we going back home to our original roots, so to speak?
Yeah. Yeah. So I do think I understand your question now. So thank you for clarifying. And I'm going to speak about this from kind of like my perspective in the United States. Um, there are a lot of gosh, okay, where do I want to start? There's so much to I think unpack with this question. So the war on drugs here in the United States was really impactful when it comes to substances in general and criminalizing substances, specifically psychedelics. And so um, this effort to, maybe try and control or help or support or keep people safe. There of course are other ways to think about that as well. And whatever the reason was for establishing these things, it became a cultural blanket for us in terms of what we saw on television, what billboards we saw when we were driving down the road, and it just became all this very negative commentary. When, in all actuality, I don't know that I wasn't there and I wasn't part of these decisions, but I don't necessarily think the evidence of what was happening at that time warranted such a government decision. And I think there are clearly other ways we can keep people safe. There are clearly other ways that we could have approached this as a society, and that is what ended up happening. And so that, right, started to communicate in and of itself that these substances are so dangerous that we don't want anybody to have them. We're going to schedule them at the highest level. We're going to say that there's absolutely nothing that these substances can contribute to us. And so by doing that, all of verbally and non-verbally, there was communication to at least our community and our society that this isn't even worth exploring, right? And instead, I should be afraid. I need to be afraid of these things. And so, if it weren't for many researchers who were around before they were scheduled, pushing this and saying, no, like, we need to keep looking at this. We need to keep seeing what's here. Let's take the wisdom of the many cultures who have been using these substances for thousands of years and trust their wisdom that there is something here. And let's see if we can scientifically explore it. And through the massive efforts that researchers went through here in the United States, I think that started to shift these beliefs and ideas about what these substances are and what they have the potential for. And so I think that disconnect, at least in the United States, really happened with this act to criminalize these substances and basically shut the whole thing down. It wasn't even like let's just, make sure they're not on the streets, but let's still explore them scientifically. It really wasn't, it was just an all or nothing kind of thing. And then, of course, that led to a whole host of other economic issues and over criminalization. And now our jails are busting at the seams. And so for decades, we're going to be trying to roll this back in a way that hopefully will repair some of the damage of what has been done. And hopefully along that way, we can also learn more about these substances in terms of what they have to offer, but also what their risks are, who they're right for, and who they're not right for.
Speaking of like short-term and long-term consequences and outcomes of it, have you seen, like I know you've like said that you've been working with some of your patients for a few years now, and what does it look like in terms of assisted treatment with someone who is been working with psychedelics, and like let's say okay I did 4 or 5 sessions over a period of 2 3 years, and then after that like okay I've stopped. Let does the does your trauma come back? What does that look like?
So we actually launched our PTSD trial about a year ago. So in terms of me working directly with people who have undergone psychedelic-assisted therapy, I'm kind of at the year mark. At this point, it seems like our treatments are, we're seeing long-term outcomes through the 6-month mark. And then we're no longer working with them anymore. And so in terms of what does this look like beyond 6 months, specifically with psilocybin. So in our clinic, we're not working with MDMA, we're working with psilocybin. And so we're really, just starting to get our boots wet with what does psilocybin for PTSD mean? What can it do? What can it not do? And how long does it last? My guess is going to be that the duration with which it lasts is going to vary from one person to another. We also know that trauma is very common. So what happens when someone experiences another trauma? Does it buffer them? Do they have tools in their toolbox that they didn't have before that will help them to not develop symptoms again? Or are they going to need another round of treatment or a different treatment or a different kind of support? So those are other questions that I have as well. We also know that people who have experienced one trauma are more likely to experience another or multiple. And so we're dealing with a population that's already at risk for dealing with multiple traumas. So that's also a protocol question or a manualized, in terms of manualizing this treatment, how do we then think about in our follow-ups, how are we helping people to maintain this and think creatively about when challenging things come up in life, what are new ways that they want to handle that? How do they want to try and handle it different? What do they think that they have now that they didn't have before that could be helpful to them so that they're ready if anything happened? Like hopefully it doesn't, we don't want them to experience another trauma. And if it does, what are we doing to prepare them?
You mentioned earlier in the interview about like childhood trauma and kids especially who are in foster homes where they don't have the right tools, or they're like their foster parents wouldn't really like invest as much for especially with their treatment, and they do suffer from PTSD or trauma from like their experiences being without a parent. Now what recommendations would you get? I know we cannot go down the route of psychedelics with kids, and there is therapy, but what would you recommend, like especially through school programs where like kids can learn to like deal with trauma, or like give them the tools without the use of psychedelics?
Yes. We have to do a better job of bringing in the different ecosystems that interact in a child's world. A child kind of passes through these different systems and they all kind of function independently, but they don't function together. And so one of the things I'm really curious about is how do we get these systems together in the same place, on the same team, working to support that adolescent. Because I think we have really good tools that can be helpful. It's just that it's so disjointed in a kid's world, right? They go home, and maybe the parents aren't involved in therapy to the extent that maybe they should. And so they're not getting the reinforcement from therapy in their home environment. And that, then they're getting new skills and strategies at school to maybe help manage their behavior. Maybe they're in the medical sphere as well, in terms of like, psychiatric medications. Maybe they're being prescribed a whole host of meds, but they're all functioning in these different spheres that aren't overlapping, and nobody's talking to each other. And so I think the best thing that we can do, even before we get to what are the best strategies for kids, is we need to get people in the same room, in the same space, on the same team. And until we start seeing that happen, it probably doesn't matter much what skills we're trying to encourage, because it's going to be so haphazard that it won't be helpful. So that's kind of the biggest thing that I'm seeing is where are our teams? How are we getting them together? And how do we support the efforts to do that? Because that takes a lot of resources. It takes a lot of time. If we think about the school system, teachers are so overburdened as it is, because they have classrooms that are busting at the seams with kids, and they don't have the time, energy, and resources to be able to individualize the interactions that they have with their students often. So it also is broader. It's a systemic issue now too, like our education system. We're also thinking about our medical system, our medicalization of mental health, right? Everything is just a medication that needs to happen. When really, what kids need is to feel safe and to feel loved wherever they are. And so how do we change the priority here, and not, this is a kid that needs to be fixed, but this is a kid that needs love, support, and to feel safe.
But in a realistic setting, like you mentioned, like school teachers like overworked, there's just not enough resources available for them to like prioritize mental health or like be there for each student, because you cannot do that. It almost seems like a chicken and egg situation where like you're never gonna reach the source of the problem. So how would one, like, okay, anyone who's listening, or parents who are listening, or anyone who is looking for the tools wouldn't be able to capture that if that's the system that we're working with. The reason I ask this is because there's a surge of like, especially with younger kids, they're more exposed to like cyberbullying, or like, the way everything is so much more fast paced than what we were used to when we were younger. And that's impacting their mental health way more than we did before. It's not about taking away their phones or not giving them screen time, because that's not happening, because the reality is that we live in this environment. So I feel like the tools we give them without like actually being there, like as like a parent or like a teacher or like a therapist, would be something which might be very simplistic, but like, okay, one caveat from that is we can't do anything else. What would you recommend there? Kind of tying your hands behind your back and then expecting you to swim, but like what?
Yeah. Right. One of the things I love about social work is advocacy. Is social work is different than psychology in the sense that a lot of times we're thinking about systems. And so how do we advocate for kids on various levels? And some of that happens at the governmental level, at this, to really impact systems, because these systems really are oftentimes that are making people feel trapped. It's making teachers feel trapped and feel like they can't be effective in the classroom. And so I think advocacy is a really important aspect of things, but I think advocacy can also happen on more of a micro level, right? Like if parents just I know how exhausting and hard it is to continue to advocate. But it is true, right? The squeaky wheel does get the grease. And so if you're advocating for your kid at school, if you're advocating for your kid in therapy, if you're advocating for your kid in the medical system, time and time and time again, and I hate that the burden falls so much on parents to get what their kid really needs. But I think if we're thinking about like what systems do we have in place right now and how do we work with them, making sure we are doing those things to encourage our parents to advocate and to keep up with those efforts, and to have professionals, right, like us who are advocating it for a systemic change, who are trying to make big differences so that the parents don't have to do so much and carry so much. And also recognizing, as challenging as it is, when kids are in therapy, the parents also need a lot of support and help. And so, figuring out with our medical system and our limited resources, how can we balance the need to work with kids and help kids, but also making sure the parents are really involved in those treatments so that not only do they know what's happening, they can reinforce those things at home, but also so we can give parents support. Because I think a lot of times parents feel very left high and dry in our space and in our culture here, to just figure it out. And that can be exhausting and tiring and feel very defeating. And so making sure we have spaces for parents to be able to have support while they are doing all these efforts to help and support and love their children and get them what they need.
Where can people find your work, or like follow what you're working on?
So we have a number of different resources at the CPDRE.org. It's not the CPDRE, it's just CPDRE.org. That's where all of our psychedelic work is happening. And if there's a listserv there, so if people want to get newsletters or they want to hear about upcoming trials, people can log in there and sign up. And then certainly finding my research online is another place, specifically the victimization adolescent work. Much of that stuff is gonna kind of fall in that space as well.
Are you on social media or anything else?
Yes, thank you. I have a LinkedIn profile, so people can search for me, Stacey Bradbury Armstrong, to connect with me that way. So you can follow what it is that I'm doing professionally, or connect with me or send messages directly to me.
Perfect. Thank you so much for coming online and speaking to me.
Absolutely. Thank you so much for having me.